IBA is scientific evidence-based treatment. We use data collection and we look at the motivation, antecedents, and consequences of behavior. We target behaviors that are socially significant. We work with autism, developmental delays, environmental issues, public health issues, education, and crime. Applied behavior analysis is a science in which tactics derived from the principles of behavior are applied systematically to improve socially significant behavior. Experimentation is used to identify the variables responsible for behavior change. There are 7 dimensions of applied behavior analysis. Applied means that we work on things that matter, things that will improve the everyday life of our patients. Behavioral means that the behaviors in which we work should be observable. Analytic means that we look to identify the functional relationship between a stimulus and the behavior that's evoked. Technological means that the procedures are written to be clearly understood and replicable. Effective means that the behavior has to be changed at a level that matters in everyday life, not just something that's statistically significant. Conceptually systematic means that all treatment is rooted in the basic principles of behavior, and generality means that we want our patients' behavior to change everywhere, not just in the clinic and not just with our staff. We want to change behaviors that will increase quality of life for our patients. We target skills that will increase independence and promote dignity. This is done utilizing the 3 principles of behavior: reinforcement, punishment, and extinction. Reinforcement is a stimulus or event that occurs following a behavior that increases the probability that a behavior will occur again if appropriate discriminating stimuli are present and similar motivating circumstances arise. Reinforcement is something that happens, anything that happens following a behavior that makes it likely to happen again. This is why we use it to change behavior. There are 2 types of reinforcement: positive reinforcement, which is the addition of something good or wanted to the environment, or negative reinforcement, which is the removal of something bad or unwanted from the environment, or even escape from the environment. For example, little Johnny wants attention, so little Johnny yells out a bad word. Little Johnny receives attention. Even though we may perceive a scolding as something bad and something that should decrease his behavior, if that is what little Johnny wanted, it's likely to increase his behavior. So next time little Johnny wants attention, it's highly likely that he's going to yell out that bad word again. There are 5 types of positive reinforcers: edibles, activities, tangibles, social, and automatic reinforcers. There's a lot going on in a child's environment, and it's important to let them know exactly what it is that they're being reinforced for. We tend to avoid hollow statements like "good job," and instead look at more descriptive statements, such as, "I loved how you used your words," or "it was cool when you came to the table quietly." When you're using reinforcement to change behavior, it's really important that you use what works or what's actually reinforcing for your patient. A lot of the children that we work with have weakened or atypical motivation, so we find that it's important to use whatever it is that they may be motivated for, even if it's access to a Kleenex, a hug, or sitting in an empty toy box. Here are a few examples of negative reinforcement. Negative reinforcement includes removal of or a break from unwanted activities, such as giving a child a break from a chore when they ask, permitted escape from a particular environment, like going outside instead of waiting in a waiting room, removal of an uncomfortable situation, like cleaning your hands when they're dirty, or taking off an itchy sweater, removal of other aversive stimuli, like if you yell at someone that you're scared of and they go away, that behavior's been negatively reinforced. So, if you're wondering what you should reinforce, it's any behavior that you'd like to see increase. For example, polite or socially appropriate behaviors, helpful or kind behaviors, compliance, or an absence of inappropriate behavior. Before you can use reinforcement successfully, you must discover what's actually reinforcing to your particular patient. Sometimes we hear people say things like, I tried reinforcement already and it didn't work, but reinforcement is a law of behavior, just like we have physical laws like gravity. Reinforcement is always effective, but we may not come up with the right contingencies for something to be reinforcing. So in your particular instance, what you used may not have worked, but that simply means that it wasn't reinforcement, not that reinforcement itself did not work. We firmly believe that the student is always right. He is not asleep, not unmotivated, not sick, and he can learn a great deal if we provide the right contingencies of reinforcement. This is one of the reasons ABA therapy can be effective in some instances where a typical classroom may not be effective. In a typical classroom, you may have up to 30 students with one teacher, but among the 30 students, you may have tons of differences in educational needs. However, in ABA, we have one teacher per one student, so our entire environment can be designed around what that one student needs to learn. To determine what's reinforcing, run a preference assessment. This should be done at the beginning of every session with a patient and multiple times throughout a session. Kids often get tired of the same things. They may not want to work for Skittles for 2 hours, or they may get tired of an iPad. There are several different types of preference assessments. The easiest way to determine what's reinforcing is to run a free operant preference assessment. During this assessment, you allow the person to explore their environment, and whatever it is that they interact with most is something that is likely to function as a reinforcing item. You can also place an array of edibles or toys in front of the patient and ask, what do you want to work for? We also utilize PECS, which stands for Picture Exchange Communication System. PECS is for our kids who have trouble vocalizing what they want. We often present them with a book or an iPad that has icons of things that they may want, and they can pick out a picture to let us know what it is that they want. Preference doesn't necessarily equal a reinforcer. It's important to note that if someone is not willing to work for something, then whatever that is not reinforcing. Also, if the reinforcement from getting the preferred item does not compete with the reinforcement given for problem behavior, the behavior is not going to change. If being yelled at is way more powerful than receiving a Skittle, and they're still being yelled at for doing something, getting a Skittle or the promise of getting a Skittle is not going to change their behavior. You also want to look out for maintaining their motivation. If a patient has free access to an item, which means that they didn't do anything to earn it, outside of demonstrating the desired or appropriate behavior, it's less likely that they'd be willing to work for that item. Why would you work for something that you can get for free? Behavior therapy sessions will not run smoothly if you let a patient have free access to reinforcement and then take it away and expect them to work for that reinforcer. Sometimes using reinforcement is hard. We are often creating an artificial motivation or a contrived motivation, a motivation which is not already present in their day-to-day lives. For example, no one follows you around giving you good Skittles for your good behavior, but in the clinic, you may see patients being followed around all day given Skittles for their good behavior. We use reinforcement to create motivation to engage in these ideal behaviors. Once the patient has learned the necessary behavior, then we start to use less and less of that contrived reinforcement and move to more social and natural reinforcement. With that in mind, there are some principles of effective reinforcement that need to be accounted for. Speed and immediacy of reinforcement is important, especially for learning new behaviors. If you wait too long to reinforce a behavior, you may accidentally reinforce something else. One way to prevent this is to always keep reinforcers nearby. Reinforcement should be proportional to the effort given by the individual or to the difficulty of the task. For example, patient X has been reading children's books with great success for weeks, but patient Y has only just begun to read whole books and they're struggling. Patient Y would receive more reinforcement than patient X because the task was harder for that patient. It's your job to be aware of the skills that your patients have. While observing, it's important to take notes on patient skills. Another example, for the first half of the session, patient Z attended and attempted all work. For the second half of the session, patient Z started to get distracted and scroll through answers. The level of reinforcement would differ based on the effort put forth by this patient. Differential reinforcement should also be utilized. Differential reinforcement occurs when you are reinforcing certain responses but not reinforcing others. For example, we'll respond differently to a patient that says, "Can I have the iPad, please?" but not respond to a patient that points to the iPad and starts screaming. We often use token economies. In a token economy, a patient earns a voucher or a token for later reinforcement. These tokens can be given out for specific behaviors like sitting at a desk or being nice, or just given out anytime the patient is good. Every token economy is different. Token economies are a version of what we earlier called contrived reinforcement. If you went up to a child and said, "Hey, do you want a check mark?" that child may look at you like you are crazy. But if you said, "Hey, do you want some cookies?" you'd likely receive a different response. This is because cookies, as food, are inherently valuable, whereas check marks or tokens are not. We have to teach that the tokens are valuable. We do this by pairing the tokens with things that are already reinforcing, like candy. So every time we give candy, we also give a token. Over time, these neutral stimuli, the tokens, will take on the conditions of the already reinforcing stimuli, like the candy. Even verbal praise has to be paired with reinforcement. Whenever you first start working with a patient that uses edible reinforcers, you need to issue an edible reinforcer at the exact same time that you use verbal praise. Over time, you won't have to use edibles as much because your praise will be just as reinforcing. Here are some various examples of token boards. Reinforcement or nah. Patients respond to instructions that are under stimulus control. If responses from you are under stimulus control, you have instructional control. Stimulus control is when the rate, latency, duration, or magnitude of a response is altered in the presence of an antecedent stimulus. Ideally, that will be you. But you don't answer a telephone if it's not ringing. Also, behaviors considered appropriate in one context are not always accepted in another, like the volume of your voice is under the stimulus control of the environment, like your indoor voice or your outdoor voice. Patients respond to SDs because SDs signal the availability of a reinforcer. You, as a therapist, should be an SD for reinforcement. This occurs by pairing yourself with reinforcement. Like if you have a kid that loves to play soccer with your patient. Or if you have a kid that loves Skittles, every time you praise them, you give them a Skittle, you'll become paired with the Skittles. You don't want to be the S delta. That's the S triangle up there. That's a signal that the reinforcer is unavailable. And in case you were wondering, an SD, it stands for discriminative stimulus. There are a few key things to remember about reinforcement. Absolutely do not remove tokens or any other reinforcement that you have already provided just because a patient is no longer behaving the way you want them to. Unless there's a specific intervention in place that requires you to do that, it's a form of punishment, and you'll learn that we tend to avoid punishment if we can. The reason for this goes back to motivation. If people can lose the reinforcement that they've earned, they'll have less motivation to work hard for that reinforcement. Imagine that you make $100 a day. You work really hard in your 8-hour day for that $100, but every minute that you're late for work, you can lose $10. If you work really hard a day for that $100, but you can lose it all in 10 minutes, what motivation would you actually have for going to that job? Another warning about reinforcement, it's essential to allow contact with reinforcement. This will never work for your patient if the individual never experiences reinforcement. This may mean that you have to shape behavior and use behavioral momentum. We'll find out that sometimes what we require of a patient is just too hard, and we have to lower our standards so that the patient can come into contact with that reinforcement. But the cool thing about shaping is that you can always increase your standards later. Shaping is the process of systematically and differentially reinforcing successive approximations to a target behavior. We may reinforce smaller steps of a bigger process. We also may use it to increase our criteria. We try not to expect perfection. We may look for success on a single task, but we try not to require success on too many tasks in a row to earn reinforcement. It decreases the value of the reinforcer, and it goes against the idea of making reinforcement proportional to the given task. It's hard to be 100% successful all the time. You know how many times I had to re-record these slides? And difficult situations require even more motivation. A behavior chain is complex behavior that consists of a relatively fixed sequence of responses. Sometimes behavior chains are utilized in a good way, like the patient may learn the chain of a conversation, like a please or a thank you. Sometimes it's bad. We may have patients that accidentally may learn that in order to give a high five, they have to scratch their head first and then give a high five because those behaviors were accidentally reinforced. Utilizing behavioral momentum is a way to increase success with difficult tasks. You start by issuing several easy instructions that your patient is very likely to be successful and compliant with. This success allows them to come into contact with reinforcement. You gradually increase the difficulty of the tasks issued until you get to a really difficult task that you want to work on. After the patient has had a string of quick and consecutive successful trials, they are way more likely to be successful with that difficult task. So in review, reinforce behaviors that you'd like to see increase, including a lack of inappropriate behavior. Make sure you know what is reinforcing. Never assume. Speed and amount of reinforcement are critical, and it must be proportional to the task completed and level of difficulty and amount of effort. I've given you brief notes on punishers. Whereas a reinforcer increases the future probability of a behavior, a punisher decreases the probability of a behavior's occurrence. A few examples of punishers include a timeout or a response cost. In ABA, we do not use punishers unless we absolutely have to. We always look to use reinforcement alone first. A reason for this would be that a punisher does not establish any new responses or strengthen any behaviors. Using a punisher only weakens a behavior and reduces the frequency of a response. We only use punishers after we were unsuccessful with an intervention that was based on reinforcement. And anytime you use a punisher, you must use some sort of reinforcement in combination. Remember earlier whenever we said that specific praise tells a patient what they should be doing? Reinforcement in general tells a patient what they should be doing. All a punisher is something that says, hey, don't do that. But instead of saying, don't jump on the couch, I may be more successful in controlling a kid's behavior if I say, sit down, instead of just, don't do that. Just as we have positive and negative reinforcement, we also have positive and negative punishment. Positive punishment would be the addition of something undesirable to the environment, like chores. Negative punishment will be the removal of something good or desired from the environment, like taking away an Xbox. Our third principle of reinforcement is extinction. Extinction occurs when a previously reinforced behavior no longer receives reinforcement. Therefore, its future probability decreases. To use extinction, or put something on extinction, we need to know what consequence is reinforcing that behavior. Then, to treat it, we change the consequence so that the behavior is no longer being reinforced. Whenever this happens, we always expect to see an extinction burst. I'm sure you've heard the old adage, it's got to get worse before it gets better. Well, that's true in this case. An extinction burst is an increase in frequency, duration, or intensity of the unreinforced behavior during the extinction process. It's very important to know that even though extinction will lead to a weakening of a response or elimination of a response, it is not punishment. With punishment procedures, we are actively adding or removing something from the environment in response to a patient's behavior. Extinction is simply not allowing contact with that reinforcer. For example, if I have a patient that is yelling in the classroom, for punishment, I may yell back at the patient, or I may kick them out of the classroom. If they're yelling for attention and I wanted to put it on extinction, which means I would want to decrease it, whenever a patient is yelling in the classroom, I would ignore it. I would do nothing. The behavior won't be maintained because they aren't receiving attention, but I am not actively changing the environment because of their behavior. Remember, we're at punishment. I would be actively changing the environment by removing the student from the environment or by adding an unpleasant stimulus like by yelling. It's also really important to note that to be effective with extinction, the specific reinforcer must be withheld all of the time. If they're receiving intermittent reinforcement, which means they're yelling in the classroom and sometimes I yell back and give them attention and sometimes I don't, the behavior is going to continue because it's sometimes being reinforced. You'll actually find that it's even harder to eliminate the behavior if it's being reinforced intermittently. Spontaneous recovery is an element of extinction. It's the temporary reemergence of a behavior that has been previously reduced with extinction. Sometimes something changes in the patient's environment and their old behaviors just come back. And it seems like it's out of nowhere, so it's spontaneous recovery, but there's always a reason even if we can't identify it. Resurgence is the recurrence of a previously reinforced behavior when the target behavior is no longer being reinforced. I've actually seen resurgence occur in a situation where we've had a patient who used to flap his hands for attention, and we taught that patient to say, "Look, please," instead of flapping their hands for attention. The flapping their hands for attention was reinforced in their other environments before they were here, but once they were required to say, "Look, please," the hand flapping stopped being reinforced. However, this patient was so motivated for attention that they started to say, "Look, please," on an average of every 5 seconds. So, "Look, please," "Look, please," "Look, please." It happened so frequently that we could no longer reinforce the patient with attention every single time that they said, "Look, please." We weren't able to get any work done. So what we had to do was thin the schedule of reinforcement for the "Look, please." So we would only respond to the patient when they say, "Look, please," every 30 seconds. Well, once we stopped reinforcing the "Look, please" every time it occurred, the patient started engaging in the hand flapping again. This is called resurgence. The previously reinforced behavior is occurring again when the target behavior, the "Look, please," is no longer being reinforced. I just want to remind you guys again that punishment and extinction are not the same thing. In punishment, the occurrence of a behavior leads to either a removal of a preferred stimulus or the addition of an aversive or unwanted stimulus. Punishment and extinction do both lead to decreased future probability of occurrence.